I will be discussing the veterans' mental health programs in the state of North Carolina. So, quick overview, we're going to be discussing the service members, veterans and family technical assistance. We're going to go over some North Carolina veterans stats, needs for the program, developmental theories, and potential success for the program. So, the service members, veterans, and their family technical assistance center works with states and territories to strengthen their behavioral health systems for service members, veterans, and their families. The SMVF provides resources addressing the behavioral health of service members and their veterans and their families. The SMVA Center monitors trends and behavioral health focused prevention, treatment, and recovery support needed for both mental health and substance abuse in service member veterans and their families, as well as the challenges faced by the states and territories. So not just focused on the veterans themselves, but what are the states and territories' challenges when trying to support the veterans. Next, I'm going to discuss the Interagency Task Force on Military and Veterans Mental Health. So the Federal Interagency Task Force works to improve the mental health and substance use disorder treatment for veteran service members and their families. Since its establishment by executive order on August 12, 2012, the Interagency Task Force has worked to implement several recommendations related to cross-agency support for veteran service members and their families. Some of the recommendations are advanced suicide prevention infrastructure and training across the agencies, so developing more facilities to get treatment and training to help make sure the veterans are being treated. They are recommending initiating data collection for joint clinical and outcome measures to track behavioral health service use and outcomes. So we want to see how many people are using the services and what are the final outcomes once their treatment is completed. We also want to build and enhance community partnership, ensure effective policy and practice integration around substance use disorder, and advancing the workforce. So we need to make sure we have enough people to support the veterans who need help, and then also bring in the community to help serve those veterans. Some of the task force responsibilities are providing an annual review of the agency's actions, defining specific goals and metrics to aid in measuring progress, and make additional recommendations as appropriate to the President. Next, I'm going to discuss some of the North Carolina veterans. Understanding demographics can give us an insight into when and how they grew up. What was society like when mental health programs were available when the veteran either retired or separated from their military service? Every veteran is unique, when and why they served, and when and why they decided to end their service, either retirement, separation, or medical separation. Nationwide, there are 21.5 million veterans, with 736,000 veterans living in North Carolina, which represents 9.8% of the state's total population. Most of the residents in North Carolina is 61 years old. That's what the average age is for veterans. 41% are 45 to 64, and 38% are 65 and older. And out of our veterans, 91% are male and 9% are female. So where did the veterans serve? So we have 475,000 veterans served in one war, 70,000 in two wars, and 26,000 served in three wars. So 14% served post 9/11, 21% in the Gulf War, which was in the 1990s, 35% during the Vietnam War, and 9% in the Korean War, and 6% in World War II. So the biggest veteran population was the Vietnam War at 35%. So where does most of the veterans reside in the state of North Carolina? The greatest number of veterans in North Carolina are the urban areas: Charlotte, Raleigh-Durham, Greensboro, Winston-Salem, High Point. Fayetteville and Jacksonville had the greatest population proportions of veterans, 18 and 16%, much higher than the state's average 9.8%. So our veterans are focused more on the densely occupied cities. So there is a need for mental health support in the state of North Carolina for our veterans. 2015, there was 210 veterans took their life, and 197 were male and 13 female. When looking at the age groups for suicide in 2015, there's an alarming age gap. So 24 suicides were from the age 18 to 34, while 70 suicides were from 35 to the 54 age group, and 80 suicides from 55 to the 74 age group, and another 36 were from 75 years and older. The statistics provided by the VA clearly show a distinct increase of the suicide rate above the age of 34. After accounting for differences in age, the veteran suicide rate in North Carolina was not significantly different from the national veteran suicide rate. So looking at the suicide numbers, the older veterans are having the highest suicide rate, which I like to think of it as there wasn't the same mental health support back in the Vietnam War, where we have 35% of our veterans. So their initial struggle, they didn't have that mental support to lean on when they came back post-war. So North Carolina struggled with PTSD. So veterans with PTSD in the state of North Carolina average 1 to 2 clinical sessions per year, while the APA's clinical practice guideline strongly recommends 4 interventions for treating PTSD and conditionally recommends another 4. All of the North Carolina's major VA hospitals are struggling with their patient loads. In 2014, the VA hospital in Durham had the longest wait time for new patient, 104 days, of any VA facility in the country, and the 7th worst wait time for specialty care appointments, 69 days. The need for such service in North Carolina is clearly from the chilling numbers the task force presents. 19% of returning North Carolina veterans are dealing with a TBI, traumatic brain injury. Somewhere between 12 and 25% struggle with PTSD, and a heartbreaking 20 to 45% are in grips of substance abuse problems. Although there are a number of factors that impact the poor outcomes observed among some veterans who have received PTSD treatment, the amount of treatment received stands out as a critical element. For example, within the context of outpatient psychotherapy, the majority of veterans with PTSD receive 1 to 2 therapy sessions per 1-year period, so an average of 1 session per 6 months. The short duration treatment stints may help explain why many veterans receiving outpatient psychotherapy do not see a reduction in PTSD symptomology. 4 interventions are strongly recommended from the EPA. So, some cognitive therapy for PTSD is derived from cognitive behavioral therapy. The cognitive model suggests a person will develop PTSD if they process a traumatic event in a way that leads to feeling of a present and severe threat. This can happen either because of an extremely negative evaluation of the trauma itself, or because of disturbance in one's autobiographical memory of the trauma. The person then re-experienced the aspects of the trauma in a seemingly uncontrolled fashion that leads to unhelpful behavior and cognitive coping responses. The brain needs to be trained to understand the traumatic event that was forced upon the patient. So some of the expected program results would be a decreased suicide rate, lower amount of domestic violence, and a reduced alcohol and drug use. With PTSD therapy and support programs increased, The amount of suicides, domestic violence, and alcohol and drug use should decrease. Veterans are still people and utilize the same method as the rest of the country. Suicide, domestic violence, and alcohol drug use are a key avenue of escape when dealing with PTSD, but with an increased amount of clinical patient centers, resources available, and reducing the wait times, we can hopefully get our numbers at least cut in half within the first 5 years. Thank you.